Welcome. I'm delighted to introduce Skye McGinty, the Executive Director of All Nations Health Center, and Dr. Melody Cunningham. They're going to start out with a little video this evening, and we'll be talking about some really pertinent topics for all of us who live here in Western Montana in regards to healthcare access.
Welcome, everyone. So we have just a short video from Partners Hope Foundation, which is the group that I'm on the board of and that many members are here, and we are building an end-of-life center and a hospice residence here in Missoula. So I'm going to show that first, and then Skye and I are going to talk about access to hospice and palliative care in rural U.S. and rural Montana, and bring up the issues of access. And at the end, we'll talk about some things that you might be able to do to contact your state or U.S. representatives and senators, because there are bills coming through that would actually help to promote access to hospice and palliative care in rural areas. And let me know if this video is loud enough or too loud, because I have control over the sound.
Often when people think about end of life, they feel that they're being asked to give up hope. And it's been said that it's not a time that we're giving up hope, but we're shifting hope from I hope that I will live to I hope I will die on my terms.
I really believe that the ability to say goodbye in the way that you want, in the place that you want, with those around that you want, is an incredible, incredible gift.
The community of Missoula has had a vision for a hospice facility for years.
Many of us in Missoula have hoped for, dreamt of an end-of-life center in our city, a place for education, a place for grief, a place for hospice, a place to gather people immersed in the field.
I see this as a way for families to really spend the quality time with their family and not be burdened with, the 24-hour, day-to-day, very difficult care.
Their family can come in there and they can be family, not caregivers. And that makes the end-of-life experience immensely better.
The center will serve 6 counties in and around the Missoula Valley, about a 100-mile radius around Missoula.
This is going to happen, it's going to succeed, and it's going to be a huge difference maker to end-of-life care in this community.
This is a community of people from all different areas who've come together to say, this is important for our community. It wanted me to use subtitles, and I didn't want to. So you're seeing what you're supposed to see. Just a little bit more background as we go through this. So my background, as you might have noticed from the video, so I was first a pediatric oncologist and then a pediatric hospice and palliative care doctor for 15 years. And so as I roll into this rural discussion, I will also discuss access for kids, because many kids live in rural areas, and even if we do have hospice or palliative care teams in those rural areas, they're often adult-based teams, and a couple things make that difficult. Certainly kids aren't just small adults, and as my husband teases, if they're a quarter the size, you just can't quarter the medication, right? Because they have different metabolism. And then we certainly know that the strain on the teams to take care of a child versus taking care of an adult has a much higher emotional toll. So we're going to roll some of that in. And I'm going to let Skye, before we start, speak to some of the American Indian issues that will also be rolled into this.
Thank you. Yeah, again, a reminder, I'm Skye McGinty. I go by she, her pronouns. I'm the executive director of All Nations here in town. I'm an enrolled member of the Little Shell Chippewa tribe and a descendant of the Shoshone-Bannock people down in Fort Hall. So the sort of anecdotes that I'm going to provide and the specific knowledge that I have is going to be related to my Anishinaabe background and my culture. Native people are by no means a monolith. We have very similar cultures sometimes and overlap in a lot of our practices and ceremonies, but every Native person and every Native tribe is different. So I'm speaking to my experiences and, again, my specific Ojibwe experience in cultural life. I will mention a couple of other specific Montana tribes and some of the practices around death and ceremony of death that I'm aware of, but those stories are for those peoples to tell and not mine to share. So I encourage you, if you are curious to know more about some of the culture around death practices with Native American people here, especially in Montana, to reach out either to All Nations. There's also really great networks of tribal members here in Missoula, really diverse intertribal folks who, when approached appropriately, would love to share that with you. So again, I'll speak to some of my lived experiences growing up in rural Montana as a Native person and witnessing, I think the big difference that rural hospice and palliative care could have, especially for our Native folks.
As you look around, you're not a crowd. You're a nice small group, so please give us an eye signal or hand raise if you want to interrupt us as we go along. Otherwise, there'll be also time at the end. Okay. We don't have any financial disclosures. No one's paying us to speak tonight or other times. As I said, we're going to talk about rural palliative care, and we have two pictures. The one on your left is actually my first real experience in providing rural care, and that is up in Kotzebue, Alaska, which is 30 miles north of the Arctic Circle. And when I was a fourth-year medical student, I had the opportunity to spend 6 weeks there working for the Indian Health Service and arrange my schedule so I had 2 weeks to backpack and see some grizzlies and other things before. So has one 3-mile road in the town, and everything comes in and goes out by boat or by plane. So it's really quite a remote location. And I left one day early because a big snowstorm came in and they didn't think my plane would come the next day.
The other picture that you see here is of Fort Belknap, Montana, up on the High Line, about 6-ish hours from here, depending on how fast you drive down the highway. If you drive as fast as I do, it's more like 5.5. I did not grow up in Fort Belknap. I grew up 60 miles away in the town of Malta, but Fort Belknap is the home of the closest Indian Health Service, where we were able to access services with my mom. It's worth mentioning that Indian Health Service is a result of the treaties that our individual tribal governments have with the U.S. government as a peer-to-peer relationship. So part of the treaties that a lot of tribes entered into, if you're federally recognized, include healthcare as a treaty, right? Because we recognize that healthcare is something that we will all need at some point in our lives. However, the quality of that healthcare was not enshrined in those treaties. That's not a dig against IHS. If you've ever accessed IHS, you sort of know what that story is like. But there are a lot of turnovers that are specific to the geographic rurality of those towns and a lot of other barriers that hinder physicians and providers and other support staff to be at these places. So a lot of the times, even though it is our treaty rights to access that care, it also is not always the best kind of care that we can receive. But because it's closest, that's why we access it. And actually this big red brick building, you can kind of see it a little bit in the distance, is the IHS building that was built in about 2000. I remember when we moved here in 1999, when I was just a kid, actually the IHS campus was just a string of like 1960s trailer houses. And you would walk into a trailer house and you would register, and then you would sort of walk over to the next one, and there would be like a dental exam chair in the middle of like this linoleum floor in an old trailer house, with like the wood paneling and everything. and you would sort of go from trailer house to access different care. And that was the care that we had until this new building was built. And so I hope that sort of illustrates the point of how hard it is to access care, in particular for people, Native people in particular, who need care in rural places. Again, even though healthcare is enshrined as a treaty right to us, it's incredibly hard to access that care, and the care is not always guaranteed to be the kind of care, level of care that we need.
Fourth, hope it doesn't drive you all crazy. So to just tag on to that, I realized for the first time when I was in Kotzebue that weather and that location can really make a difference in outcomes of even things that we would think of as fairly simple. So when I was in Kotzebue, a young 20-something man came in who'd fallen from a ladder and struck his head on a concrete floor, and clearly had an internal bleed, but there was no one, there wasn't time to fly him to Anchorage, and there was no one there to put in what they call a bolt hole or something to take the pressure off. And so he actually seized and died in our emergency room with, no ability to, provide intervention. And it was quite a realization, having grown up around hospital access that was pretty readily available. So our objectives, and we hope we meet them, to talk about some urban and rural designation and definitions. I promise they won't be boring. Some rural palliative and hospice data, both national and, as I said, pediatric specific. And we're going to talk about the Native or the American Indian issues with that. Telemedicine and telehospice. So I think we've all heard of telemedicine, particularly in the era of COVID. There are also telehospice services that can be provided, and there are a couple studies that I pulled on the pediatric realm to talk about the effectiveness of those. Rural demographics and the needs, and then some advocacy and policy opportunities. And all of them are bipartisan, so there's nothing that will be challenging or anxiety producing. So the U.S. data on rural really ranges from, in some studies, they say 17 to 49%, varies on the studies, of the U.S. are rural. And those designations vary based on who's making the definitions. And they're actually important because grants and healthcare and other opportunities can be available or not available based on the designation of rural or not rural.
Are you talking about population, 17 to 49% of U.S. population, or are you talking land here?
The 17 to 49% of the U.S. land is considered rural. There's some other where we'll talk about a CDC slide where they say that 15% of Americans live in rural designations. And those definitions are a little bit varied, as I said. You bet. And anyone sing out with questions. And if the audience can't hear, let me know and we'll repeat them. There's administrative, land use, and economic concepts associated with this, and some varied socioeconomic characteristics that impact health and well-being. And research projects and economic development programs are two of the things that are particularly affected by definitions, because they might pull on a quote-unquote rural population, but it depends on how that population and how that land area is designated. And sometimes whether they call it rural or what they're looking for in rural depends on the endeavor or what they're looking for to gather the data.
Give this thing 5 seconds to warm up. Yeah, the thing I wanted to mention here was just the population density of Native people in rural versus tribal versus urban communities. It was actually a statistic that really surprised me when I started doing grant writing for All Nations 5 years ago, that 70% of Native people actually live off reservation and in urban areas like Missoula, like Cincinnati, San Francisco, due to intentional policies set forth by the U.S. government to force us to assimilate into to white mainstream culture. And so across Montana, you really see that closer to about 50%. That's largely because we don't have a lot of urban areas. But you see about a 50% split between Native people who live in urban areas versus rural and tribal. So we see a really high concentration, especially of the Indian Health Service budget in tribal communities. But really, a lot of the need is in urban areas. But that often means that our folks who are living in rural or frontier areas of Montana aren't serviced at all. And we all know how long it takes to drive across Montana. Even, 90 minutes is a long time, especially in a Montana winter.
Yeah, 90 minutes can become 180 in no time flat. So this is looking, and maybe this gives a little bit better visual for Nancy and others. So this looks at, and as I said, the definitions can be slippery and a little mind-boggling, but metro areas, and you can see that those are in the orange, and much of the metro areas are designated and clustered along the coasts. And included in those metro areas, which are defined as greater than a 50,000 population, are the outlying counties. And they define it in this particular look at 25% of those people in those outlying counties commute into the city. And again, yeah, Anne.
I was looking at Montana, and if you use those same definitions, this map is 10 years old. And so if you look at Flathead and Bozeman, they would both be considered metro at this point.
Thank you. I love that we have other expertise in the audience. And we'll talk a little bit more about Montana later as well. And then non-metro are still relative urban clusters with 10,000 to 49,000 people. And then they just call non-core the rest of the country. And you can see there's an awful lot, even though it's an old map, there's an awful lot of gray non-core areas. So we're going to talk a little bit, Skye has already mentioned frontier. So I never had heard the term frontier until I was moving here and I was giving a grand rounds about Montana and rural areas. And frontier is defined variably, but the first definition I learned was that there were less than 6 people on average per square mile. And Montana reaches that threshold, although there are some other thresholds for frontier as well. And this was a picture of my very first visit to Montana when I did a January snowshoeing and wolf discovery tour in Yellowstone at 25 below and couldn't wait to go back. So frontier communities, like I said, the first definition was 6 people per square mile or 6 persons per square mile. Other definitions are 12 to 20. And this is, Skye was just talking about distances to get to hospitals. Never mind getting to hospitals. How about service and just a market or a grocery store? And so frontier communities are deemed to have 30 to 90 miles or 30 to 90 minutes. I guess everyone drives 60 miles an hour instead of 80 between the home and the market or service. Go ahead.
This is not a necessary comment. I just feel like we should also measure frontier communities and how many cows are in the county. It's Montana. Like, I feel like we should have some kind of metric. I feel like in my county, in Phillips County, it's like a 30-to-1 ratio to people. I think we're considered frontier in that way. Anyway.
I like that definition. That's livelier than my definitions. And again, these definitions and the numbers that they collect depend on exactly the parameters that they use. But on this that came from the National Center for Frontier Communities, it said that 56% of U.S. land is frontier and that 12.2 million people live far or 60 to 90 minutes from market and service centers, and that Native Americans live, and this said 1.1 million. I don't know how that determines based on the the entire, that sounds actually a little low. And that 19 states contain 95% of the frontier areas, which when you travel up and down the west and east coasts and down along the south, you realize that they don't have nearly as much open space as we do here, or a place like Alaska, for example. So this is the one from, these are data and information from the CDC. So they looked at causes of death, and I think this is important to look at when we're thinking about access to hospice and palliative care. So in their definition, 15% of all Americans live in rural areas, and rural Americans are at the greater risk of death from these 5 leading causes. And I think you can read them. So heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke. And those 4, other than the unintentional injury, are likely patients that would benefit from palliative care and or, then hospice. And we didn't define palliative care at the beginning. I've lived it for so long, it didn't even occur to me. Shall I give folks the difference between palliative care and hospice? Would that be beneficial? Yes. Okay.
I have to tell you one thing. I don't think there's such a thing as
intentional. So hospice is actually it's a Medicare and Medicaid benefit. So it's really an insurance benefit, and that's how it started. And it is for patients who have a prognosis of 6 months or less, and they're eligible for services for hospice at end of life. Now, certainly there are patients who enroll in hospice who live much longer than 6 months, because we know that prognosis is murky. But that is the definition. Palliative care are for patients who have chronic, complex issues and who could benefit from having additional services that manage their symptoms, like pain, like nausea, fatigue, and other symptoms, as well as having the additional services of social worker, home visits from nurses and physicians, the chaplain, sometimes palliative care services, if they're really complete, will have art therapists and music therapists and a very broad range of people to help with patients who are going through chronic, complex illnesses. And patients can be involved in palliative care actually for many years. It's another layer of support. It's also another help for decision making, because I can attest to myself as an oncologist, when I practiced that, being very close and having a very long relationship with a patient and a family from diagnosis, it is harder to prognosticate, because even we as the professionals, we don't want our patients to be at the end of life. So to have another team, a palliative team, come in and help to ascertain prognosis and help families to decide what decisions are the right decisions for them can be helpful. So rural challenges for palliative care, there are lots of them. There are chronic workplace shortages. There are workplace shortages in every sector of society now. Even before COVID and before other issues, we've had workforce shortages for hospice and palliative care clinicians, and the gamut, the social workers, the chaplains, the nurses, the physicians. Financial, there's sometimes a lack of direct payment and reimbursement, and I know Carla grapples with this with partners in home care for both the home care and the palliative care and hospice services. The availability of support services, so hospice, home care, behavioral health, we know is a real issue in Montana and around the country, as well as social service. And I will tell you that one thing that came out of the last legislative session that I think is really important when we talk about availability of support services, there was a bill put through that allowed, it has been passed by the governor, and now the Department of Labor and Industry has to figure out how to implement it. But it enabled parents to be paid for care of their kids with chronic complex illnesses, because we know we don't have enough home health aides. I know from my own experience in taking care of patients and families, the person, the home health aide or the nurse who's supposed to come is sick or just doesn't come. The parent has to call in sick to work, and ultimately it becomes a vicious cycle, and they sometimes lose their job over that. So the ability for them to get paid and be able to stay home with their child is amazing. And the fact that, in my experience, almost always the parents are even better caregivers than the most professional home health aide or nurse, because they love their child and they know their child well. And we don't have enough research models to look at rural challenges in palliative care.
And I wanted to speak a little bit to this availability of support services as it specifically relates to our Native community. You'll see in here American Indian, Native, Indigenous. Those all have their own meanings, but for these purposes, I'm using those sort of interchangeably. In our Native communities, there is a huge access barrier just to regular health services, much less this additional specialty need. Like with IHS, a lot of the times Native people get referred out anyway because those specialty pieces of care are not included in our treaty rates, and therefore we're having to drive an additional 3 or 4 hours to go to Great Falls or Billings, and then you're putting up with a long wait list. There's also very little culturally competent care, both from my personal experiences and what I've heard from other Native people, my family and clients of all nations, where you just don't feel safe accessing those resources because there might be a prejudice or a bias against you because of your skin color or because of the way you present yourself in that exam room. And just that fear of being mistreated is enough to keep Native people away from accessing those services. Another important thing to note just around, especially with our elders in hospice care, elders are one of our most important people next to our kiddos. They would say probably 1 or 2. But our elders, the care of them is not something that we lightly entrust with anyone. That responsibility really falls onto the family. And in a lot of Native families, mine in particular, we believe that you die in the lodge. You don't go to a place where other people are also experiencing end of life. And we take care of our own, whether that's our extended family or our immediate family. And so you run into a lot of sort of cultural mismatches between Western medicine and Indigenous medicine that might not always align with the needs of the specific Native American community that you're working within. So when we talk about support services, we're talking more for our Native community, more than just resources or programs or certain service provisions. We're also talking about, to your point of having a chaplain there, we're talking about having a medicine person there who is able to deliver them their rights. We're talking about having smudge accessible to those people and to the relatives who are helping that person through the end of their life. We're talking about being gathered together as a community, and that's why COVID was so intensely hard for our Native community, because we gather when people die. And when we're not able to observe our cultural practices and our ceremony, another part of our culture sort of falls away. And to not be able to provide that to our elders, who out of all people we should be able to honor with that respect, is incredibly difficult for our Native community. So just sort of keeping those things in mind too as we go through that, there is a little bit of that misalignment between Western medicine expectations and Indigenous medicine expectations.
Skye, while we're on that topic, would you just speak to the proximity of where All Nations Health Center is going to be built next to Partners Hope Foundation, and how that might help inform us and the caregivers from Partners in Home Care?
Yeah, All Nations will be about 30 yards away from Partners in Home Care. We're calling it sort of this campus of care, knowing that the Hospice Center will be there. All Nations will be in the middle, and then there's an eventual housing component, which we know, to me, housing is really the nexus of our care. If we don't have a safe shelter, the rest of our health deteriorates pretty quickly. But the ability to sort of diffuse our culture across and also fill in the gaps that All Nations cannot provide, I think is such a valuable service to this community in Western Montana in particular. I think Missoula has such a great appetite for that kind of work that our two organizations are doing. And for us to sort of tag team the care of palliative care, I think is really going to be impactful as soon as that building's built.
Thank you. And I have lots of slides, but I think the conversation is much better. So if I zoom through some, you'll thank me.
Can you talk a little bit about, I think about the fact that 125 years ago, back in the turn of the century, in my understanding, and correct me if I'm wrong, is that Native culture was still taking care of their own health care through Native practices and such. And I even think about, 120 years ago that, most people, I think, who was the first president that was born in a hospital? I think it was anyway, that most of the care went on in people's homes, and in the Native culture, it happened between Native members. How much of that traditional medicine continues to be practiced within the Native community?
Sure. So there's certainly a revival of those traditional practitioner services and programs. I would say as of 1492, really since white contact first happened, that was when our culture really got interrupted. So when we are separated from our land, from our children, from our language, our culture then is taken from us. I would say in the most recent past, even in the last 100 years, a lot of our ceremonies and practices were illegal. They were made illegal by the government so that we weren't able to care even for our kinship ties who have no blood relation to us, which is how a lot of our Native families constitute themselves. You don't have to be related to someone to consider them your relative or your cousin. And it was a very intentional policy by the U.S. government to separate us from our ceremony, from our traditions, from gathering our herbs and our medicines that really move the needle on our health at the end of the day. And so I would say now, ever since the AIM movement really in the 70s, there's been a resurgence, especially in the past, I would say 5 years of what I would call Native pride. I think my grandma, for the first time in her life, she's a boarding school survivor. She is now proud to be a Native person. She sees herself as a brown person. And beforehand, she always considered herself white because that's what she was taught. And so I think there is that resurgence of culture that is coming back. It comes back to sort of this financial piece too. We can't get reimbursed from Medicaid for providing smudge services or doing a talking circle or holding a sweat lodge, which is really a bummer because that is health. That is health and wellness to our Native people. And we know that culture is a huge protective factor against substance use, against child mistreatment, against a host of other negative health outcomes. And so All Nations in particular, we have a traditional practitioner on board that we are trying to always elevate his services. But again, our culture has been interrupted for so long. Those people are very few and far between who have the rights to deliver those practices to our Native communities. So it's an uphill battle all of the time, but it is something that All Nations and really the network of Native people in Montana are working to bring back.
So in terms of opportunities in rural areas for palliative care and for hospice, so we'll turn to some positives. There are some strong networks and relationships, and any of us who've grown up or lived or visited rural communities, we can palpably feel that in those rural areas. We need to provide available training, and there are opportunities to do that, to provide for people for practitioners in those areas they can build on their own long-term patient-provider relationships and bring in a new skill set that can be learned from the outside. And many of the needs are met locally. It's really the patient and the family preference. I think whether we're local or whether we're urban, we often want our services local. We often want to be at home. And then we'll talk a little bit more later, too, about telehealth alternative or adjunct. And it was made permanent in 2021 here in Montana, the extension of the COVID telehealth availability so that you're able to provide it. There are not some of the stipulations were previously that you already had to have a patient-provider relationship before you could provide telehealth, and that has gone by the wayside. So I think that's a progressive and wonderful law that's been passed in Montana that hasn't been passed in every state around the country. And then we can help to use national standards and best practices. So some of the recommendations based on those challenges and opportunities are to have integrated technology. You know, can't have home-based telehealth care if you don't have at least an iPhone to provide, or a phone to provide that. And that's another thing that was built into the Montana law, is use of alternative technology. So it can be voice-only telehealth in Montana, whereas in some other states you can't provide that. And improving the access to the home-based care through telehealth, decrease windshield time. And we know there's a lot of windshield time in Montana, and sometimes for a hospice team or a member of a hospice team to do a home-based visit might be a 4 or 5 hour, round trip, maybe even one-way trip. So telehealth and telemedicine are really important. There's also telemonitoring. There are ways of monitoring vital signs through telehealth, either electronically or to have someone local. And they had this actually way back when I was up in Alaska. They had community members who were trained to go in and take vital signs and to provide other data that was important to the clinicians who were farther away. So those increase access. They improve timely assessments. They also allow for more impactful home visits. So you can imagine if you've met a family, or a family has met the care team via telemedicine, and then they have an in-person visit, that is more impactful because you've already developed some relationship. And so the impact of having traveled that time to meet them in person, not to mention that traveling a far distance to meet a family in person often feels really meaningful to the family that we went through that effort. They won't fully replace home visits.
Yeah, the only thing I would mention around sort of integrated technology, I think especially in COVID, we've shown just the power of telehealth and telehospice, just the increased availability, especially in such a remote state as Montana, I think really makes a difference to our rural communities. One thing to keep in mind, especially with tribal and rural communities, is that there often isn't infrastructure built in that would facilitate that sort of telehealth care, especially on reservations in Montana. I think there's only one that has access to broadband. Of course, there have been some congressional bills that have been passed to provide funding specifically to build that infrastructure. But for Native people who are really in survival mode, the last thing you're sort of thinking about is like internet or like dish network access, which is gravy, but you're also thinking about, not commodity food. You're thinking about your house and getting new windows and making sure it's winterized. And so one thing that would be my recommendation, something that All Nations did over COVID, and it's different in an urban community, right? We were able to do sort of a technology checkout thing that we were able to supply those Wi-Fi hotspots and a tablet to someone. They were able to meet with their behavioral health specialist, anything that you can do basically that doesn't require a physical interaction due to COVID, we were able to facilitate through that technology sort of rent out program. And that's certainly something I could see a mobile clinic doing out in really rural areas, so that you're turning that 4 or 5 hour trip into something that you can make a lot of impact with by providing those tablets and just facilitating that for people to access, so that not all of the responsibility is on them to ensure that they have ways to reach our providers.
And I would speak to it, another benefit of telehealth, that even with in-person visits, coming to an office you might not see. So with a telehealth visit, we can say, could I meet your dog? Show me what's special to you in your home. And you really can have people show you things that they might be able to tell you about when they come to the office. And certainly they would show you if you did a home visit. But that has been some benefit that I have seen in some of those visits that I've done in the past.
I would also just say one more thing. That is an excellent way to build trust and rapport with our Native community, is to physically show up in spaces where they cannot access care. So bringing care to them goes a long way, especially from non-Native providers, to say, we are here. We see that you have maybe an issue with access, whether that is transportation or telehealth, and we are willing to literally meet you where you're at to provide that care. It's really a cultural thing, I think, but making it more about like the community and more about the family or your dog, and involving other people as your relatives in your care is huge. We don't see our care as just me as the individual. It's our community, it's our family. It's the health of those people who live around us. And so going into the home and really making it more of a personal touch to that care, I think goes a really long way in bridging that gap of trust.
And in that, I imagine, and I've seen in my work, that it changes the locus of control, right? Because when you visit someone in their home and you're learning about them in their home and assessing, for me, their child's symptoms in the home, it's their place. They're in control of it, as opposed to, coming into the office, never mind schlepping long distances with, if you have someone who is technology dependent, you're carrying the oxygen, you might be carrying the ventilator. There's lots of things that make that really a challenge. So in terms of thinking about rural America and pediatric health, I don't think it's any surprise to you that in rural America, many of our pediatric patients have increased chronic complex conditions, partly because of socioeconomic issues that often strike in our rural areas, as well as access to health care that's as timely. And the mortality in these groups, in infants, in neonatal, which is infant to a year of age, and postnatal for the patients as well as for the moms, is those mortality rates are higher in rural areas. These are the slides that I am going to skip, and I always hate when someone does that, but we are only about a quarter way through our slides, and I want to make sure that there's time for you all to ask questions. It's been great that everyone's been participating and that we've been able to do our back and forth. So we're talking again about telehealth and telehospice. I loved this picture because it's the stethoscope coming out of the computer, and it really can personalize, and you really can get good information through telehealth. So there was a study that looked in the U.S., and PPC is pediatric palliative care, and it was a telehealth study, and it was a pilot study from July of 18 to July of 2020 with rural zip codes in Nebraska, and looked at pediatric cancer patients. They were taken care of, again, by adult hospice teams, because there aren't very many, are not sufficient pediatric teams, but then there were pediatric provider telehealth visits as support to the family, also support to the adult teams. These patients had terminal cancer, and the purpose of this was to look at symptom burden as well as the impact on the family of having these additional support visits. And it was home-based care, adult hospice teams providing care based on standards of care, and then the pediatric telehealth visits. The children were, there were 11 of them. The mean age was 11.9, and the visits by the pediatric telehealth team were every 14 days. And there were 4.8 on average additional that the family initiated. So they felt like those first visits were helpful, and they initiated different additional visits. And the range from time to death was 4 to 95 days. And with the support of the pediatric telehealth teams, all of these patients were able to die at home, which was the family's wish. And when we look at this, I think this slide, the very first one about pain severity, is probably the most telling. And so from dark to light, it's the first visit, the second visit, and the third telehealth visit by the pediatric team. And you can see that the the pain scores went down. So there was really impact on the pain in these patients when the pediatric telehealth team was involved. The other symptoms, sadness, worry, and fatigue, either went up or didn't really change. Those are certainly symptoms and emotions that are much harder to impact. And so what they determined was it was feasible. Symptom issues, particularly the pain. Oh, I'm sorry. Thank you for calling my attention.
Not really a question, more of just well, it's kind of a question. I'm thinking about those things like worry and anxiety, and I am not yet a professional. I'm just doing some research, though, on psychedelics and, plant medicine and chemical medicine as well. And I know that there's a lot of plant medicine used in Native communities, just in, traditionally the kinds of things that were prohibited by the U.S. government. And I'm wondering if you're seeing a resurgence in the use of those kind of substances to ease those, sort of non-pain issues, although they do, some research suggests that they do relieve pain as well. So.
Yeah, I would say the one example that immediately popped into my head is bear root tea. So that's something that we ended up harvesting as an all nations team right at the height of COVID in order to provide to our Native clients. Bear root tea, along with immunization and social distancing and all of that, has really been shown to have a positive impact in our Native communities. Bear root tea being really focusing on your lungs and your upper respiratory system, sort of clearing those airways out. Aside from sort of the physicality of the tea, there's also the prayers and the medicine that go inside of the tea. And so there's also that cultural piece that's brought into whether that's you're smudging with cedar or sage or sweetgrass or drinking bear root tea. There is a resurgence in that, I would say, based really on availability. I think in Montana, we're particularly lucky to have held on to a lot of our culture here, in particular with our neighbors to the north in Canada. There's a lot of that diffusion across this man-made border that we live within. And I think the availability of medicines within this particular valley is also really astonishing. There's always sort of the deference to our cultural keepers on whether or not it's appropriate for us to do so, who gathers it, who harvests it, who ultimately disseminates it, who also provides the prayer and the blessing that goes within the tea. So I would say that, yes, there is that resurgence there, but I think it's heavily, heavily dependent on the cultural presence inside that particular community.
There was another study also in the Midwest, a telehospice study where there were 15 patients, 15 hospice nurses, and the average distance was 172 miles from the home with a range of 30 to 450 miles. It's quite a trek to provide care. The time saved using telehospice was 8 hours on average per patient. The visit consisted of caregiver support, assessing quality of life and trying to help with quality of life, talking about goals of care for the patient and the family, symptom management, and review of medications to make sure that the medications were understood, that they were being utilized in the best way, and whether medication dosage changes needed to occur. So they looked at the results, and they asked the question, is telehealth quality care the same as in-person care? And the parent, and this was again a pediatric study, said in a statistically significant manner, and one asterisk means that for anyone who likes statistics, it's less than 0.04 of a p-value. And then the nurse felt even more strongly that it was the quality of care was the same as in person. So 2 asterisks on that graph say that the p-value was less than 0.01. and then parent and nurse, again, whether telehealth was acceptable. And you can see statistically significant yes on both. So what they concluded is that, no surprise, there were pediatric palliative provider shortages. There were adult palliative care and hospice provider shortages. There was a role for telehealth and telehospice. It's an acceptable mode of care delivery. It improves the cost of delivery, and it really needed to look at more of a longitudinal and a broader study. So I talked a little bit earlier about Montana telehealth, and so House Bill 43 permanently lifted some of the telehealth limitations that were in place before, and that was signed by the governor on April 19th of 2021. So no longer is it required to have a patient-provider relationship before starting with telemedicine. It lifted restrictions on geographic proximity and location, which in a state as big and rural as Montana is really important. And as I said, it allows additional technology for telehealth. So we've talked a bit about culture, and we know that culture is the cornerstone of much of life and is certainly the cornerstone of care. And we've probably all heard the terms cultural competence, and I think sometimes I feel like that's a V8 moment. Like, how can we possibly really be culturally competent? And there are so many cultures, and how can I feel competent in a particular culture? There was a study that was done, and we'll look at it, looking at cultural safety. There have been trainings on cultural humility, which goes along with cultural safety, really walking into the patient and the family knowing that you don't know a lot, and they are your greatest teachers to help provide care and to help you to know how to best provide care.
Yeah, I would just make a plug for a training that I recently went to back in March. It was called the International Meeting of Indigenous Child Health. A lot of representation from American Indian people, but it truly was international. There were Aboriginal people from Australia. There were people from Fiji, Cambodia, Colombia. And what I thought was really interesting, the specific focus on child health. Even though, our cultures are thousands and thousands of miles from each other, we all dealt with colonization. Like, the impacts of colonization were very, very similar on us. The separation from land and culture created basically the exact same health disparities across the board in different countries that are the exact same that we see in our indigenous communities right here in Montana. The biggest three being diabetes, cardiovascular disease, and alcohol and substance use. And in particular, when we're thinking about child health too, there is a lot of stock that goes into traditional medicine, where, a Western provider is not really welcome in those spaces. The first deference goes to that traditional person who is able to provide that child with some level of care and comfort. And then Advil and Tylenol is kind of seen as the secondary, not as legitimate kind of medicine. And the very interesting thing to me in that conference was, again, that even though we were colonized in very wildly different ways and by different people, the outcomes of colonization were still the same for our people, which I think speaks to the inherent indigeneity that all of us have, that we are all connected in some way. But I also think it speaks to the specific resilience that Indigenous people have when facing really tough oppression, that always returning back to culture and returning back to tradition is really what uplifts our health at the end of the day.
So this was a compilation of studies, and it looked at rural and small towns of Indigenous peoples in Canada, the U.S., New Zealand, and Australia. And they went through and did a literature search to try to find information on this, and they'll talk here about competence versus safety. So in terms of thinking about cultural safety, the background is we really don't know a whole lot about it. You need to define cultural safety from the standpoint of palliative care and end-of-life care. And through their literature, they identified some strategies. And so cultural competence, what they looked at in the studies, and I think what we could attest to is that it can improve care, but there's no decolonization of care. It doesn't really recognize a lot of those past traumas and past issues. Culturally safe care can also improve care and decolonizes care, and we'll try to translate that into words and ideas that are understandable.
Yeah, if I can jump in, I think it's worth mentioning, even as a Native person and even as a Native organization like All Nations, there is no way for a person or an organization to be fully culturally competent across the board, right? Like Melody mentioned, there are so many different cultures that we share in Missoula and across the world. Even as a Native person, I can be culturally incompetent to a Dene person down in the Southwest or a Seminole person. And so there's really this broad definition of what culture is. And so even though, that might seem a little defeatist of how could we ever be culturally competent if there are so many cultures to learn and so many ways to mess up, I think really the philosophy behind it is the most important. I think being open to being told that you pronounced someone's name wrong or told that you made a misstep in a protocol, right? There's no way for one person to hold all of that information in their head and act appropriately. There's just not. But there are ways that you can act appropriately and receive that feedback in a good way in order to provide the care that someone feels safe receiving from you. So I just wanted to provide that caveat that culture is this big nebulous thing that we should all partake in and celebrate and respect. But there's always going to be a culture out there that we don't align with or doesn't resonate with us, but somebody in our care does practice that culture and they deserve the same level of care as anybody else. So yeah.
And I think having the humility, as you said, to receive that feedback and listen to that feedback, but also having the humility to say, I know I'm going to get things wrong. Please help me to know that. Please step in. Please tell me. So really opening the door to being told, because that's not always the case when anyone comes into a practitioner's space. So in terms of the cultural competence strategies, which we're not saying that these are bad, but they are just incomplete and they miss some of the mark. So symbolic and small gestures can be important, just insufficient. Anticipating barriers to access, asking about them, and then really deference to the client, family, and community. And we'll see in a minute how that's different from cultural safety and collective decision-making with the family and the practitioners, and having family involvement versus from the safety strategy.
Yeah, I would also say just sort of trusting people to make their own decisions with their health also goes a long way, and being rather in a strengths-based approach rather than a deficit-based approach to care. I think particular minorities, we are told a lot of the times what is wrong with our communities. And we know it, we live it, we see our relatives going through it. We know the issues that our communities are up against. And facing it more in a strengths-based approach of this is what is going really well with your health. These are the things that we see that are really contributing well in your community. And sort of flipping it on its head to say, we know there's a lot of bad things that are happening in our own personal health at a micro level and on a macro level with our community, but sort of bringing it back to that hope piece so that person isn't just walking out feeling like you just pointed out every single thing that's wrong with their health and their community.
And then these safety strategies, I think, are more in-depth and more open. So not only just involving the patient and the family in the discussions, but really in the service planning, like bring them on board, make them part of it, and really have an individual as well as a systemic reflection on racism. It exists if we don't acknowledge it exists, if we don't talk about how it exists and how we may personally have some. I wish I didn't, but I know that things come out, and I think it's important to reflect on that. And the clinician reflecting on implicit and explicit biases, and there are some surveys and things that we can do to help us to uncover our implicit biases. Accepting the history that the family or the patient tells us, and embracing history as being part and present in the clinical encounters. And I think you can speak to that. And then the community ownership of the services and the worldviews.
Sure. Yeah, I think one thing that's that I want to mention is specifically Alaska Native culture. There is a healthcare foundation called the South Central Foundation up in Anchorage, and all of their care is what they call relative-based, customer-based. Their specific tribal members own their care. They're basically stakeholders in this health facility. And that is a sense of decolonized care that you really don't see anywhere else in the world. I think it's something the lower 48 could learn a lot about. But it's really about less centering ourselves as the arbiter of what is right and wrong with health, and centering our community as they are the experts on their lived experiences. They are the experts on their particular health and what they are seeing in their community. So really bringing it back from that individual level of care, and again, involving the community, involving your grandma and your aunties and your uncles, is what's going to resonate with a lot of Native people. Sort of that model of care you're talking about.
Was there, I feel like I missed an identifier that you gave for that, or a way
Yep,
of
so it's
thinking
called the NUCA system of care, NUKA, specifically trademarked by the South Central Foundation, and it's specific to Alaska Native people, but really that model is culturally applicable.
And so in terms of their conclusions as they looked through this, that culturally competent strategies may catalyze cultural safety framework, but may not, may contribute to organizational inaction. And what do I mean by that? If we think we're culturally competent, full stop, we don't try to go further. And it can dilute the culturally safe efforts. And the culturally safe strategies really invite, as Skye talked about, decolonization, awareness of colonialism, racism, and discrimination, and a commitment, a real commitment to partnership and power sharing. So we'll talk, go ahead. Oh. I wish I had my phone with me.
Yeah. What kind of training is available to clinicians for, the culturally based strategies that you're talking about?
So there is some training on what's called cultural, they call it cultural humility, but based on what I've, had of it and taught it, I think it really speaks to cultural safety. And it's really, I would say, so there's training for that, and I think that the biggest thing is going into encounters knowing that we don't know a lot, and having the humility to ask, having the humility to get feedback, and having the humility when we realize we've made a misstep to say, I'm sorry I made a misstep, help me to know how I can do this better. So really, I think humility is the basis of cultural safety, I would say.
There's also a really excellent program that's actually housed in Kalispell, and Missoula has an affiliate of it too, that trains doctors and FNPs. I think it's just for those two particular providers to be prepared to provide services in rural and tribal communities. So they get placed in IHS facilities, they get placed in rural access hospitals, and they really get to understand the unique needs that community has around health. It's about like shadowing those providers in those spaces. So people who are sort of in, their last couple of years of residency, they're able to go and get that experience regardless of where they want to practice. It's sort of that culturally safe piece. I would say one piece of that where I think maybe that program or maybe other programs fall short is, as I can only speak as a Native person, we are so used to non-Native people coming into our communities, staying for 2 years to get their student loans paid off, and then they leave our community. They are completely gone. And so you see a new provider every time you go in. You don't know if they're going to be there in 6 months or not. It's terrible to get on the wait list. And we sort of see that systemic abuse in our communities where someone comes in, they get what they want, and then they leave, and then they never contribute to that community ever again. And so I think that's probably where that cultural competent piece is missed. Even if you don't want to live in rural Montana, that's completely fine. But there are a lot of ways to give back to tribal and rural communities that extend beyond sort of this residency program or just staying for 2 or 3 years to get your student loans paid off. There are ways to show up for that community that could be, direct assistance, mutual aid, volunteering. There's a lot of ways to sort of incorporate yourself into that community. And I would just say as Native people, when non-Native providers come in, we really feel that you're here to get something that benefits you and then you're leaving.
So I'm just going to talk about two. These are federal bills that are out there. So one, the name is Palliative Care and Hospice Education Training Act, and it's PACHETA is its acronym. It's Senate Bill 2243, and again, it's a federal one. It's bipartisan. There were 17 co-sponsors, 19 Republicans, 6 Democrats, and 1 independent. So in this era of lots of partisanship, it's nice to know that some things really are truly bipartisan. And what can you do? I looked up just to get the most recent information about it before speaking, and it has been presented to committee. I've already contacted our senators because it's S2243, so it's in the Senate. So contacting it's easy enough to write an email. If you go onto the websites, if people want more information about how they're able to do that, please feel free to come up and I'll give you contact information for me and I can help you to navigate it. There's also Telehealth Expansion Act, which is H.R. 1843, and it passed the House Committee Ways and Means, the House Ways and Means Committee. So it's passed on June 7th, and it also is bipartisan with 32 co-sponsors, 26 Republicans and 6 Democrats. When I looked at it, it's passed the committee, but right now it doesn't look like it's sitting anywhere else for us to contact people. But I think like what we have in Montana, it would be important to have that passed federally.
So I think this might pertain to other people, but for instance, I have a child who's had a chronic health issue and recently was trying to reconnect with his doctor at the Mayo Clinic and requested, I just was trying to get on the internal health system to message his doctor, but because it had been over a year since he had seen my son, I could no longer access that message. And when I requested a virtual consultation, they said that since the COVID protocols are over, that the doctor outside of the 4-state area that the Mayo Clinic state licenses or the Minnesota licenses extend to, he can't do a virtual consultation. And so I'm just wondering if that limitation, if this act will address some of those limitations.
That's a great question. So will this help if you've had, a certain duration, whether it's a year or other, from seeing a practitioner and you can't, get back to connect with that practitioner and they won't then see someone who's a state away because of the laws changing. I didn't read the whole text of this, but my sense is that something like this would enable federally for people to, just like in Montana, not have those geographic restrictions in terms of being able to provide telehealth. Because you can imagine things like, I know pediatrics best, pediatric rheumatology, how many of those are there? Pediatric palliative care physicians, there's one in Montana, and Chris Johns does primarily adult palliative care, but also does some pediatrics. So there are certain subspecialties that we really, really, really need telehealth in order for people to be able to access them, because there just aren't enough practitioners. So I'll take a look at the text of it and let you know. So why Western Montana needs end-of-life center? I'm circling back to Partners Hope Foundation as well as Montana. So in Western Montana, 740 families annually receive hospice care, in-home hospice care. We're aging. we have one of the fastest rates of aging in the country. And I think second only to Maine, we are the oldest state in the country. 40% of our patients or our population who are 75 and older live alone. So having a residence, having a place where they can go if they need care and they don't have family members who are able to provide it in the home. And veterans comprise 10.3% of our total population, and the only state with a higher population is Alaska. And we know that many of our veterans will need palliative and hospice care. And then 75% of our population in the 6 western counties that we will serve live in rural areas. So we know they're not going to have wonderful access. Just wanted to look, I think we all thought that we would no longer have report cards after we graduated from whatever our final was, and I guess you're still in it, so you might be getting a report card. But the Center to Advance Palliative Care does a report card of the U.S. and the different states around the U.S. in terms of availability of hospice-based palliative care and compares it to national and regional. Community palliative care, which our hospice residents and end-of-life center will be, the number of palliative care clinicians, and then they look at ways to advance palliative care, both the quality and the access through workforce, improving payment, clinician skills, and public awareness. And so if we look around the U.S., you can see that can I expand it? You can see that the very dark blue really score 100 on their report card all the way down to the dark orange that receives a 0. And I pulled a slide particularly for Montana, and we receive a C at 52, a score of 52. So, and it's not surprising. Rural states are going to have more difficulty having palliative care access for their population. Say that again. I want to make sure everyone hears.
So North Dakota and South Dakota, is that the dark blue or is that a different color? What's their score is what I guess I'm trying to say. They're doing pretty well.
There is, if you go on to CAPC and look at it, you can actually hover and it will give you the score. But you're right, those are, it's a little surprising that those are dark blue, and I don't know why. I should, but I don't. So from the standpoint of Partners Hope, our mission is to build and sustain a state-of-the-art hospice center that provides end-of-life care, education, and support for our community. And as Skye has mentioned, we're going to be side by side with All Nations Health Center, which I think is going to be, and what did you say they call that?
Campus of Care.
Campus of Care. I love that. And as you
put me on the spot. Let's see. I should. All Nations is committed to providing healthy, sustainable lives for our Native people and the surrounding communities through culturally based holistic care. Got it.
Woo!
Thank you. Also, my board member is here, so I'm really glad that I remembered that.
Excellent. And then we envision a community where end-of-life care can be enriching and transformative. And it truly, for anyone who's walked through it, hopefully with a family member, with a caring team, or from a professional standpoint, it really can be transformative. And I call it sacred. We have a very diverse Western Montana community. And life is a journey, and we want the end of life to be a beautiful journey as well. So much of who we are is where we've been, and it's a great way when we're taking care of patients and families to learn where they've been. It's really a gift for them to share that with us. And this last, I just love these. I think both of them depict journeys. And I love that we've had audience participation, but we'd love to hear any other questions, stories, thoughts that people have. And thank you for coming.
Those are beautiful. Beautiful.
I thought they were beautiful too. I wish I was the artist.
I just mostly want to thank Skye for the best definition of cultural competence and safety that I've ever heard. And I wish my first of 3 trainings had said that from the beginning, and I would have understood it a whole lot more. So thank you for that.
Well, thank you all for coming. Thank you for allowing Skye and I to have our back and forth. I would love to do more of these.
Thanks, everyone.